you have to examine for all the peripheral pulses, including the radial pulse, brachial pulse, carotid pulse, axillary pulse. These are erythematous papular rashes, which are mainly present over the buttock and over the extensor surface of the knees. In case of the myositis, polymyositis, or polymyalgia rheumatica, in that case, muscle problem will be more prominent. Chronic fatigue syndrome. Before that, I would like to discuss about the eosinophilic granulomatosis. I think it's already the Wegener's and the eosinophilic granulomatosis, these are all described in respiratory medicine very well. So since we are discussing again in the rheumatology section, I would just like to show few points that can lead you into diagnosing three different types of vasculitis. Basically different types of vasculitis. For giant cell arteritis and Takaysu-arteritis. In giant cell arteritis, aged male are affected. Takayasu, young female of reproductive age. And in case of the giant cell arteritis, common symptoms are basically headache, scalp tenderness. Basically the temporal artery is affected here. So headache, scalp tenderness, and jaw pain or jaw claudication. On examination, temporal artery, commonest complication related to the giant cell arteritis is blindness. Because one of the branches from the temporal artery is the ophthalmic artery, and here in the giant cell arteritis, if not treated promptly, in that case it can cause anterior ischemic optic neuropathy. So that can ultimately lead to blindness, which is why after suspecting a case of giant cell arteritis, you have to refer the patient to an ophthalmologist as soon as possible, and treatment should be started with high-dose prednisolone ASAP. Otherwise, permanent blindness can take place. So these are the common features that will help you into making a diagnosis of the GC or the giant cell arteritis. Takaysu-arteritis takes place commonly in young female, particularly female in reproductive age group. Here, Takaysu-arteritis actually the involvement can be any part of the aorta or the subclavian artery. So it depends which part is affected. Commonest is basically some systemic complaints can be present, such as fever, malaise, weight loss, anorexia, joint pain. So these are sometimes can be present. And asymmetrical blood pressure. This is a asymmetrical blood pressure. That means if if you measure blood pressure in one hand and blood pressure in the other hand and compare these two, and if the lesion is proximal to the subclavian artery, in that case in the inflamed area or in the vasculitic zone you will get high blood pressure, but on the other hand you will get no blood pressure at all. Similarly, if this is distal to the subclavian artery, then you might get asymmetrical blood pressure between the upper limb and the lower limb. And similarly, the affected blood vessel, for example, the lesion is taking place distal to the radial, like any part along the radial artery, maybe distal to the subclavian artery. In that case, there will be loss of pulse. So basically, asymmetrical blood pressure and loss of pulse or absence of pulse. This is very common and important examination finding. So that's why in suspected Takaysu arteritis, you have to examine for all the peripheral pulses, including the radial pulse, brachial pulse, carotid pulse, axillary pulse. You should check for the subclavian pulse as well. Femoral pulse, popliteal, artery dorsalis pedis, anterior tibial, all these pulses should be examined thoroughly, because depending on the level of the inflammation in the large vessel, these pulses can be either absent or diminished. And at the same time, you have to look for if there is any bruit. So bruit basically means abnormal sound. In the inflamed area, of course, the blood flow will be interrupted, which will cause an abnormal sound production. So commonly look for the carotid bruit and the subclavian bruit, as well as for the renal bruit. So bruit examination is also very important finding. And in Takaysu-arteritis, because it's a large vessel vasculitis, it can commonly lead to neurological or cardiovascular complications, either in the form of angina or myocardial infarction. Hypertension is a common feature in Takayasu arthritis, especially in young patients, and neurological complications such as stroke, transient ischemic attacks. These are all commonly seen in case of the Takayasu arthritis. So both of this condition, steroid is very, very important as a part of the management. And in addition to the steroid for Takayasu arthritis, because there is lots of cardiovascular and serious complication related to the Takayasu arthritis, that's why low dose aspirin should be given to prevent this thrombotic complications, 75 milligram. So these are the main features of the giant cell arteritis and the Takayasu arthritis. Now, in terms of the medial vessel vasculitis, medium size, that is PAN versus HSP. So HSP actually is more discussed in renal medicine, but still I will give a little bit of brief description here. PAN I have already mentioned, like some look for the clue hepatitis surface antigen positive or known case of hepatitis B virus. Concomitant hypertension might be a possibility. Livedo reticularis, skin manifestation. Look for the wart testicular pain in case of the male. Look for if there is any neuropathy present or not. And look for if there is any abdominal pain, which can be due to mesenteric ischemia, abdominal pain. So these are basically polyarteritis nodosa diagnostic clue. And for Henoch-Schönlein purpura, mainly rash, mainly distributed, where these are erythematous papillary rashes, which are mainly present over the buttock and over the extensor surface of the knees and the lower limbs. Then bloody diarrhea, joint pain. Hematuria is a plus minus. In polyarteritis nodosa, renal impairment takes place. Hematuria is not that common. So, but in Henoch-Schönlein purpura, hematuria is a plus minus. So for treatment, basically for PAN, that is again steroid and immunosuppressants, and that is cyclophosphamide plasma exchange. And for HSP, actually symptomatic and supportive, and nothing is needed. Sometimes prednisolone can be given plus minus, and in extreme cases, plasma exchange. So now we will discuss about the small vessel vasculitis. So for the granulomatosis with polyangiitis or the GPA, and another one would be the EGP or the eosinophilic granulomatosis with polyangiitis, also known as the Sharp-Strauss. And this is known as the Wegener's. In terms of the ANCA that is associated, for granulomatosis, C ANCA is positive. For the eosinophilic, P ANCA is positive. Then both of these are actually small vessel vasculitis, but in granulomatosis, look for clues like epistaxis, nasal crusting, nasal deformity, or upper respiratory tract infection like sinusitis, coryzal illness, things like that, mainly. Along with that, there is lower respiratory tract infection features. There can be concomitant cranial nerve palsy. This is a plus minus feature, not always present. And other systemic complaints can be present, and glomerulonephritis in the form of hematuria, proteinuria. Clue is mainly this nasal problem that will give you the clue. And of course, skin rash can take place because these are both vasculitis. So this is for the GP or the Wegener's granulomatosis. Now, in terms of the eosinophilic, three stems you should definitely consider. That is asthma. It's one of the asthma plus syndrome. So patient on examination might be having wheezing or rhonchi, and known case of asthma, but with bronchodilators, symptoms are not well controlled. And after prescribing with leukotriene receptor antagonist, that is LRTS, symptoms are worsened in case of the eosinophilic granulomatosis with polyangiitis, because in asthma problem is with the bronchospasm, right? Because of the high type 1 hypersensitivity reaction. So this actually the Montelukast helps in the mast cell stabilization. But in case of the Sharp-Strauss, problem is within the blood vessel. So there is already increased eosinophilic permeability. So there is already increased capillary permeability and vessel damage. So with the mast cell stabilizer, it will actually cause further deterioration of the symptoms. And look out for symptoms like eosinophilia. There might be mention of eosinophilia. And look out for mononeuritis multiplex. So any neurological or neuropathy that look out for these clues. Like asthma plus, after prescribing Montelukast, symptoms have worsened. Peripheral blood showing eosinophilia, and patient is having any form of mononeuritis multiplex. So that goes in the favor of Sharp-Strauss or eosinophilic granulomatosis with polyangiitis. Treatment is ultimately steroids and immunosuppressants.